was hoping to have a panel discussion, but unfortunately I am the lone representative of the various services that I'm going to give a highlight to, which it's too bad for them, because it just means that I get to talk more about the research that I'm doing. So hopefully that'll give you a bit of a context to this discussion. So my name is Matthew Leyenaar. If I haven't met you yet, then there was some quote about Bilbo Baggins last night that went around, but I'm not going to say that. It's been a great time being here, and lots of great conversations, and certainly I hope that before we wrap up, if you have questions, that you can come and approach me. And if you didn't see me on Twitter, I'm there. So I'm going to start out with a map of Canada, because it's a big place. And I've been asked a bunch of times about where I'm from. And if I say Canada, that doesn't really narrow it down. But I've through my research, I've been in conversation with various leaders of community paramedic programs in Alberta and Calgary, at a bunch of different centers in Ontario, as well as Nova Scotia. And what I'm going to give most of the overview is around different programs in Ontario. So people ask where McMaster University is. The red dot there represents Hamilton. That's one of the services that I've been working with, and that's where McMaster is. That's where I live now. Toronto's the big city that's closest to us. The other end of the province is where Ottawa is, our capital city. And just below that, I put a little red heart to show the town where I grew up, a small town south of Ottawa. So I say I'm from Eastern Ontario, but that doesn't mean a lot to people outside of Canada. And County of Renfrew, which has sort of claim to fame from Mike Nolan and the work that he's done. So I'll talk a little bit about them. York Region is made up of a bunch of different municipalities that are suburbs of Toronto, north of Toronto, and Windsor, which is south of Detroit, for the Americans. And the fun thing, if we've had this conversation also with different people, that all of these place names look pretty familiar, right? Like I think we could look at a map of England and find, well, not Ottawa and Toronto anyway, but I don't know, is there a Hamilton? Yeah, so anyway. York Region, their sort of big project and one of the studies that they're doing is called the EPIC study, and it involves partnering with primary care and chronic disease management. And so there's going to be a couple of themes that are going to emerge as I go through these different services, and you'll see sort of some common themes that I'll get to towards the end. The city of Hamilton had a program that used to be called CHAP. They call it CP at Clinic now. And they partner with community housing to set up wellness clinics and community paramedic programs within community housing locations, specifically that are senior subsidized housing or that have a high frequency of calls to those locations. Down in Windsor, they have a program that they've started that's called the Vulnerable Patient Navigator. And to borrow a term from Mike Sanderson, the chief of the Hamilton Paramedic Service, if you're trying to find a nice way to say frequent callers, Mike Sanderson's done it by calling them loyalty clients. And to the extent that he has different membership levels, so there's silver, gold, and platinum. So he presents that as the way to describe these individuals. So that's Windsor's really working on their own service identified loyalty clients. County of Renfrew is a more rural and remote area. They have a handful of different projects that they're doing. One of them is they call it the Community Paramedic Response Unit, which uses community paramedics in dual roles where they can respond to emergencies as required, but they sort of have a scheduled list of clients that they're going to see over the day. And Health Links is a provincial program in Ontario, I guess looking at the loyalty clients of the healthcare sector as a whole. So these are identified by local health integrated networks, a regional health authority for overall high-use patients. And in Renfrew, one of the community paramedics is involved in developing coordinated care plans with different care providers for these particular individuals. And I couldn't find a picture of Nova Scotia as EHS, so apparently looking at cute animals is a thing here, so I thought I'd throw that in. And apparently it also improves your level of attention, so we may see a few more of them before the afternoon's out. Nova Scotia is really interesting, and it's been mentioned a couple of times while we're here about Long and Briar Islands and different things that they're doing. Conversations that I'm having with EHS in Nova Scotia are around how they use the extended care paramedic model for deployment to long-term care homes. And also they have paramedics that are participating in palliative care programs as a sort of on-demand response for palliative care patients. And if anyone was in Saskatoon, this slide I included in Saskatoon last summer. I took this out of my the condo that I was staying in, and I couldn't quite figure out whether the bridge was being built or taken down. And I think that's one of the tensions that we have in community paramedicine. Are we trying to build something new, or are we trying to take away something old? And the background here is that they wanted to take the bridge down in the winter time when the river was frozen, but then the river thawed, and so they couldn't complete that, and they started building the new bridge while the old bridge still stood there. Anyway, the question is, so what? So we've got these different models of care, and we've been talking a lot about models of care over the course of yesterday and today. As a researcher, it's my job to draw on what's happening, and as Peter was saying, ask the question first. So my research project I've entitled "Common Assessments for Repeated Paramedic Encounters," drawing on the Latin word of carpe, and really considering what do you seize on, what are you picking out in the assessments that you're doing. So there's sort of three objectives behind my research. The first one has to do with case finding, and really specifically targeted towards individuals that are experiencing either social isolation or functional decline. And that's a really simple way of saying that these are individuals who are calling because they have no one else to call, or their health is deteriorating in a way that other care providers haven't caught on to. So how do we find those individuals? And what outcomes do we measure with them? I'll speak more to that in a little bit. And then it's really answering that question, well, why the paramedic? And I think that that's a struggle that we need to be able to articulate to a broader population, the general public, just as much as it is our partners within the healthcare continuum. And so within this is, well, the assessment. And really, when we think about it, assessment is just determining what's wrong. That can vary from community to community, and as I've shown in the different communities that I'm working with, they each sort of have their own take on the program, and it's similar to all of the presentations that we've seen here, tailoring it, whatever we're doing to the community need. But we share a common background, and I mentioned this at the last IRCP in Saskatoon. If I were to poll all of the paramedics in the room or test them on what they were taught for that rapid head-to-toe assessment, that 2-minute primary survey, ABCs, medical or trauma, it's not going to vary very much between Canada and the US and the UK and Australia and New Zealand and the Netherlands. There might be subtle differences, but we share this common background in the way that we assess patients. And so what does that look like within the community paramedic domain? What is the ABC rapid assessment, that initial assessment to determine what's wrong within community paramedicine? And the project that I'm leading is working on really capturing the full breadth of observations in a standardized way. We've talked yesterday about standards, and there is this whole sort of machinery around education, how people are taught, what are they taught, what are they doing, and the way to bring it all together that's where the standards come in. The questions we ask, the things that we observe, what we plan to do, care plans have come up a lot, what information that we share, who are we collaborating with in these care plans, what treatment are we giving, whether that's wound care or whether that's something that's pharmacological, and then when do we reassess? And I think that I really challenge each of you to think about that, as far as you're going to know that something has changed because you've done a reassessment. And similar to that rapid head-to-toe assessment that you would do in a trauma, and we talk about, well, how quickly would you reassess somebody that suffered multi-system trauma? How quickly do you reassess somebody that's in a community paramedic program? And so although we have different settings and we have different types of patients and different goals, in the conversations that I've had with these different partners, I'm realizing that there is this ground where we can lay the framework for a common assessment. And I've invited a few members who are in the room here that I've met through IRCP and other folks from the services that I'm working on to really try and do this project in an integrated way, to have the knowledge on the ground. So in Canada, we use the phrase integrated knowledge translation, knowledge transfer, knowledge exchange, knowledge mobilization. It's got, I think, about 50 different terms within the research sphere of how to get researchers engaged with practitioners to collaborate towards solutions. And so I asked this panel, well, how do we assess patients in community paramedicine? And these are sort of specifically some of the things around who do you see, what do you assess, and why? And so here's this is response from 14 different members of this panel. And what I'll draw attention to here, obviously the majority goes to community dwelling older adults, and I think Duncan and Joanna did a really great overview of explaining this as this is our clientele. It's reassuring to me to see that that's a common thread amongst the panel that I've talked to. But there are these other things, and what I'll draw your attention to here is that next largest segment, which is palliative care. And I don't think that we're talking enough about paramedics' role in palliative care. and the role of community paramedicine in advanced care planning and end-of-life directives. And then the other thing that came out here is that pink segment, and respondents who indicated other were asked what that other was, and it was the general public, just general population, general public, which I think isn't really surprising, but it does go to that sort of what are the outcomes when you're thinking about a specific population. You can think about specific outcomes, but when you're thinking of the general population, it sort of changes your perspective on what it is that what service you're providing. So one of the other things that I asked them was around what are the needs that they are assessing, and pretty much everybody would indicate that they're asking questions around pain management. They're asking questions around unmet mental health needs, and they're asking questions around activities of daily living. So that's a good start. Okay, that gives me as a researcher something to work on. The interesting thing here is that with respect to, while most respondents indicated they're asking questions about mental health, they aren't asking about substance abuse treatment, and they're not asking about risk of violence or harm to self or others. So there's sort of some specific things there that you can ask broadly around mental health. And if your program is targeted at mental health, then those are some really key sort of side roads to go down as far as looking at specific questions to ask in your assessment. But the next two on that list there, around the need for palliative care and the need for a comprehensive geriatric assessment. So if you're serving community dwelling older adults, do they have a geriatrician that has seen them, that has assessed them, that has really considered how the intricacies of their comorbidities work? When you're talking earlier today about having multiple care plans, I forget, it was that you, yeah, multiple care plans for each disease process. This is where a comprehensive geriatric assessment really comes into play. And also for Peter and Peter this morning around nutrition, in the members of the panel didn't really say anything about nutrition. It was kind of like, yeah, I guess, but to think about food security and how that relates to the social determinants house, it's an important question to be asking. And so while we look at that sort of the needs that people are asking about, then, well, why? What are you measuring in your program? And now everybody says about repeated 911 calls, that loyalty client question comes up. But no one's measuring the functions in changes in functional status. So whether frailty is improving or being stable or worsening, disability. And this also sort of, more people look at disease symptoms, but even less than half were looking at, they weren't keeping track of mortality rates of the patients that they were enrolled within their programs. Now, this is sort of the last component of this survey of these different providers. And when you first look at this, you think, oh boy, like, yeah, everybody's doing something different. But when you look at the first question around what period of time a program is designed to interact with patients, and so there's roughly a quarter there that is just sporadic as needed. That's kind of the extended care paramedic model. That's they call when they need us, but that's about it. And then that 14.3% is a really narrow window of 0 to 7 days where the paramedics are identifying some specific thing that's a quick fix. There's something there. It's just a simple referral that this patient needs to have this service, and if we can hook this patient up with this service, then we know that they're going to stop calling us. But the rest, so the other 3/4 or 2/3, I guess, are all within that sort of greater than 1 month. So this is an ongoing process, an ongoing relationship, where it really provides the opportunity to establish a care plan, to establish an ongoing relationship, and to be able to look at changes over time. And that comes back to sort of the framework is, if you have a common assessment that you have taught your staff to do at the beginning when they first see a patient, then it provides you the opportunity to do that same that same assessment at the end, whenever that patient is discharged. And that's a really key sort of take-home message is, if you just say goodbye to your patients, you aren't going to be able to measure what you've done for them. You aren't going to be able to speak to those changes in function, the changes in disease process, and I think that's a really important message to be able to share. And the other question here was around, what period of time do you have to see on that initial visit? And while, again, there's 2 respondents that said only 10 to 20 minutes. What Duncan and Joanna were talking about today of stopping the clock and waiting an hour to get the patient to the right care, as opposed to just taking them to the emergency where they're going to wait hours for the wrong care. Taking the time, and most respondents would say that they have this, that within their community paramedic, that sort of is built in. And it's encouraging to me to see processes in place where care plans can be initiated by the emergency responding paramedic to allow that time for the real, let's just stop the clock, stop fighting the clock, assess this patient in a comprehensive way so that we can determine a care plan that's really going to benefit them. And so, yeah, common assessments for repeated paramedic encounters. So different settings, different types of patients, different goals, but a common assessment. And the process that I'm working through is drawing from different validated scores and criteria. And so these are some of the algorithms that are built within the assessment tool that we're developing. One is a vulnerable persons at risk indices. So this has 3 different levels of patients, and it's used to identify those patients who are going to be most at risk if there's a state of emergency. And this algorithm, this indice was developed out of the earthquakes in Christchurch, New Zealand. The next one on the list is detection of indicators and vulnerabilities for emergency room trips. And this is something that my PhD supervisor developed. And it's designed to identify home care clients who are at risk for repeated trips to the emergency room. Another one here is the assessment urgency algorithm used to identify in the emergency department to identify patients who need a comprehensive geriatric assessment. And we're including a frailty index, and then also a trigger towards a brief mental health screener to look more in detail. That's sort of the side road that I mentioned earlier. And yeah, this is all really easy. That's my sort of bit of sarcasm. But. Yep. Any questions?
respondents. Are you finding consistency across different nations in the types of responses and where you could be heading?
In broad strokes, yes, and I think that that's being reflected over the course of this conference. There are some subtle differences, but for the most part, it's quite consistent.
So as you're looking to fill the gaps then with things like home health care, in the United States, they're coming up with new CMS rules that these at-risk populations should be identified and an emergency plan set up.
Right.
I work for the state of Wisconsin Disaster Management Healthcare Coalitions, Northwest Wisconsin region, and I've brought it to their attention a number of times at state meetings that we should be looking at the community paramedic program.
Yep.
In order to fill that gap in the event
Exactly.
of an emergency. This is the perfect individual to rapidly respond and go out to these at-risk patients and either provide them with care, transport, whatever their support needs are. And so are you looking at that too? I mean, have you?
Yeah, that's one of the things that I think it's an easy sell, right? Is that particularly in Ontario, where sort of the emergency management structure starts at the municipality and the paramedic services are working at that level, they know that if there is a state of emergency and it starts at the municipal level, that the people are going to come and ask them, right? They're going to ask them that question. Well, who's at risk? And so this is the exact sort of way to determine that, because this takes into account their living arrangement, what their social, like to go back to social isolation, the individual that doesn't have anybody that's going to check on them, they need someone to check on them. And that's going to be the paramedics in a state of emergency. So yeah, that's really, I think, a really valuable aspect of our role as paramedics, to be able to yes, do this preventative and proactive aspect of healthcare, but not forget our aspect of emergency management and really, be a champion of that, to say we know what patients we need to go check on and we have a plan where we can go and see them. So.
All right, we'll be hearing more from Matt in a little bit. Okay, we're a little ahead of schedule, so we're going to take the first after break speaker and move him up to before break. And then we should end the day a little bit early today.